So most often, carotid artery disease, again, is caused by same atherosclerotic risk factors. Unfortunately, screening of these problems, unless people decide to go through screening programs such as Lifeline or our screening program that we have here, don't get found until often the primary care doctors have listened to the neck arteries and heard what's called a bruit, or basically turbulent flow in the carotids, at which point that forces the doctor to obtain an ultrasound. And with the ultrasound, then we can put the patient into a category of a mild, moderate, or severe stenosis. At that point, then if it's approaching the severe range, we talk about surgical treatment. But even along the moderate disease spectrum, it is still putting the patient at an elevated risk of stroke. Generally, these patients, other than having strokes or TIAs, which are mini strokes, they don't have any significant symptoms to know about. So screening is very important for people who have atherosclerotic risk factors. As far as carotid artery procedures are concerned, we've been performing these procedures, and vascular surgeons in general, for the typical carotid endarterectomy, which is a standard incision along the neck to open up the artery and remove the plaque since, the last 50 plus years now. But in addition to that, over the last 20 years, carotid stenting has come around. And here at PCI and through our association with the hospitals, we can perform now more minimally invasive procedures such as Transcarotid Artery Revascularization, or TCAR. And what that involves is a small incision at the base of the neck, and it allows us to directly access the carotid artery at that level using what's sort of a filtering technique to perform a carotid stent for patients who are at higher risk than average. Many of the patients, because of the same risk factors of atherosclerotic disease, are at high risk from a heart perspective, and so these procedures do need to be done in the hospital setting. But with the transcarotid procedures that we do, it reduces not only the risk of stroke from the procedure, but it reduces the risk to the heart as well. So when we do these procedures, it's in a combined procedure with an operating suite that has fluoroscopy, which allows us to use X-ray to see, the arteries and the contrast and wires that we use to perform the procedure. But TCAR is one of the premier changes in vascular surgery over the last, really actually only 5 to 7 years, which has drastically lowered surgical risk to patients in a more minimally invasive fashion, which allows people to return to their usual activity quicker and have reduced that risk of stroke from their carotid artery disease. TCAR is a relatively new procedure. It started originally, I believe, got FDA clearance in 2016. And we were lucky enough to be chosen as one of the relatively early adopters in Iowa. Originally, it was the program in Des Moines, and then we were the second program to open in Iowa. And now there are a few other places doing it throughout the country. But originally, when this procedure started and we got involved in 2017, quality outcomes data is very important in this because it is a new procedure. And with carotid lesions, as we said before, you're preventing a stroke. So it's very important to have high quality outcomes when you're treating patients who are asymptomatic. And so just by nature of Iowa's population aging and having other risk factors for heart disease, we were very early adopters of the technology, and partnering originally with St. Luke's, not only the program at St. Luke's, but both Dr. Lawrence and myself have all become and recognized as centers and providers of excellence in transcarotid revascularization. And what that's allowed us to do is treat a very large number of patients with very good results. we're, again, like I said, early adopters of the technology, and now because of originally this was considered for high-risk patients alone for one reason or another, but we do expect, because of the excellent quality outcomes, that TCAR actually will come out with a standard risk indication, much like transcatheter valve replacement has. But that should be upcoming in the next, actually, 1 month or so. The biggest difference is how invasive the technique is. The old operation of an endarterectomy involved an incision basically along the entire border of the neck musculature to expose the carotid artery. And then we'd clamp off the vessels, open up the artery. Basically, I tell patients it's like filleting the artery open, and then you scrape the plaque out from the inside of the artery, leaving what good tissue is behind. And once you do that, you create a good area of flow where there's no problematic lesions left behind. And that operation, it's a great operation. Takes about 60 to 80 minutes to do. Overall, about 2 hours in the operating room. And generally, patients still go home the next day, and usually with relatively little pain. The only other option for higher risk patients that we used to have was transfemoral carotid stenting. And transfemoral stenting has been around for quite some time now, but because of the risk profile of causing a stroke, which was actually about double that of open surgery, you had to have had a stroke to qualify for a previous carotid stent. With the safety profile of transcarotid stenting through a smaller incision just at the base of the neck, we're able to treat asymptomatic patients because the risk factor for having a stroke during the procedure is almost exactly equivalent to that of open carotid surgery. And that owes a lot to the sort of filtering technique, which essentially is sort of like short-term bypass for the brain when we do this operation. And it's been very, very effective and has led to very quick recovery times and quick return to activity for almost everyone who has the procedure.